Good afternoon, everyone. I am Dr. Khalid, consultant radiologist from Vijaya Diagnostic Center, Hyderabad. I welcome you all for today's clinical radiological webinar on intussusception. And for today's discussion, we have two eminent doctors, and it is my pleasure to invite our chief guest, Dr. Sravanthi. So she did her MBBS and MS from Gandhi Medical College, and she did her MCH from reputed Institute of PGI Chandigarh, and she is the associate member of Association of Surgeons of India, and she is a member of International Pediatric Surgery and Oncology. She has multiple publications in reputed journals of pediatric surgery and neonatal surgery, and she is now practicing as assistant professor in Siddhartha Medical College, Vijayawada. And we are honored to have you, ma'am. Next, we
Thank you.
have and we have Dr. Manoj. Dr. Manoj is our consultant radiologist in Vizag branch, and he did his MBBS and he did his MBBS from Andhra Medical College, Vizag, and he did his MD from reputed Institute of PGI Chandigarh. Okay. Before I give the stage to Dr. Manoj, Dr. Sravanthi ma'am, uh, we would be happy to uh, we would be we would be happy if you can enlighten us with the clinical perspective and your clinical experience with intussusception. Over to you, Dr. Sravanthi.
Thank you, Dr. Khalid. So coming to pediatric intussusception, it is usually seen in infants and toddlers between 3 to 3 years of age. Most of them, almost around 90% present less than 3 years, and out of this, around 40% present between 3 to 9 months of age. Most of times it is idiopathic, there is no specific cause, and it is seen at the time of weaning when they change from breastfeed to a top feed, which is associated with the enlargement of the Peyer's patches, which might cause the intussusception, acting as a lead point. So clinically, they usually present with pain, recurrent, crampy, which is increasing in frequency as the duration of symptoms increase, and they have vomitings and perrectal bleed, which is called current jelly stool. And rarely you can palpate the intussusception per rectum also. It is said that the intussusception babies are never malnourished. They're usually healthy, chubby babies which present with these symptoms. And so most of the time the patients are stable unless until they present very late with severe signs of obstruction or peritonitis. And usually, because the intussusception is ileocolic most of the time, we see that the right iliac fossa is empty, which is called as a Dan sign on the clinical examination, and you can feel a sausage-shaped mass in the right hypochondrium, more towards the umbilicus and upper abdomen.
If clinically you are suspecting intussusception, what would be your next line of investigation? What would you suggest?
So we usually ultrasound is the most diagnostic investigation which we ask for. And when we send the patient to a radiologist suspecting intussusception, we expect a report which says what is the anatomical position of the intussusception, what is the length of the intussusception, are there any associated fluid collection in the abdomen or fluid within the intussusception segment, and what is the vascularity of the bowel which is stuck in the intussusception. So based on this, it will give us an idea of should we go for a non-operative management or an operative management.
Okay. I think we'll move on to the presentation now. Dr. Manoj, the stage is yours.
Okay. Is my slide visible?
Yes, Manoj. Yes.
Okay. Thank you. I'm Dr. Manoj, discussing diagnosis and management of pediatric intussusception. So, what is intussusception? It is basically an acquired imagination or telescoping of a proximal bowel segment into the lumen of the immediately adjacent distal bowel segment. So, the proximal portion of this, the proximal bowel segment is called as the intussusceptum, and the distal segment is called as the intussusceptions. And it is the most common cause of intestinal obstruction in infants and young children. So, as ma'am said, the most common age group is from 3 months to 3 years, and almost all the studies have shown that there is a male predominance. Uh, there is also seasonal variation present, which actually suggests that there is an underlying viral etiology. There is also correlation noted with prior or concurrent respiratory infections, otitis media, gastroenteritis, and even in Enoch-Schonlein purpura. Most of the cases are idiopathic in nature, with approximately 3 to 10% of the cases showing a lead point. The common causes of the lead point are duplication cysts, the hemangiomas or polyps, or Meckel's diverticulum, lymphoma. An important thing to remember is as the age of the child increases, the prevalence of the incidence of the lead point increases. So, what are the types of intersusceptions? The most common, the one is the ileocolic type, and there's also the next most common one is the small bowel type, which is subdivided into ileo-ileocolic, ileo-ileal, jejino-ileal, or a jejino-jejunal type. The colocolic type of intersusception is relatively rare. Coming to the clinical features, the classical triad is that of pain, a palpable sausage-shaped abdominal mass, and a recurrent bloody or red current jelly stool. And the type of pain is actually a recurrent severe paroxysmal colicky type of pain, with the child being relatively normal in between the episodes of the pain, at least during the initial part of the duration of illness. This triad is actually present in only 30 to 40% of the cases, but if there is pain as well as abdominal mass, there is a 90% positive predictive value that this could be intersusception, and the predictive value increases to 100% if all the three of them are there. The other clinical features include vomiting, abdominal distension, lethargy, fever, peritonitis, and shock. So, what actually happens in intersusception? So, there could be an underlying GI infection, or new food proteins might have been introduced, which leads to hypertrophy of the Peyer's patches in the terminal ileum. So, once that happens, there is prolapse of the mucosa of the ileum into the colon. So, and once that happens, the peristalsis takes over, and it propels the terminal ileum along distally through the colon. So, what happens next is the mesentery gets constricted, and there is obstruction of the venous return. And because of that, there is edema of the intersusceptum, which is the inside part, and that leads to increased mucus secretion as well as bleeding. And because of the edema, there can be compromise of the arterial blood supply, which eventually leads to bowel infarction and eventually perforation. So, coming to management, the most important thing, as in any disease, is would be an early diagnosis. But in this case, early diagnosis would mean lesser morbidity. And why is that? Because there is higher chance of non-surgical reduction in these cases, which basically means decreased incidence of surgery. And even if the baby lands into the operation theater, there are lesser chances of bowel dissection. Here I would like to show a case of a 10-month-old child who presented with intersusception and came for pneumatic reduction. The duration of illness in this child was approximately 5 days. Because the patient was neglected, we can see that there is paucity of bowel gas in the large bowel, gas show in the large bowel, and we can see an ill-defined mass-like structure in the region of the rectum. After insufflating some air, we can see the apex of the intersusception in the rectum or the rectosigmoid region. So we were not able to reduce this intersusception, and it probably it went till up to the somewhere proximal portion of the left colon, and this patient had to undergo surgery with bowel dissection, and that is why early diagnosis is very important. Coming to the modalities that are available for us are ultrasonography, which is the investigation of choice. Then we can do radiography or fluoroscopies, and the other CT scan is generally not done, but it can be helpful in inconclusive cases or atypical cases, or if there is any suspicion of any malignancy. So why is ultrasound the investigation of choice? It is because it is readily available and it is non-invasive. But the most important point is that there is no ionizing radiation. And in these cases, in the suspected cases of intussusception, ultrasonography is also confirmatory. So what are the signs that we actually see in intussusception cases are the target or donut sign, a pseudokidney sign, and a crescent in donut sign. The target sign means refers to presence of hyper as well as hypoechoic concentric circles around the central echogenic fat. The hyperechoic ring is corresponds to the mucosa or the muscularis layer of the bowel, and the hypoechoic part is the submucosal part. And this appearance is generally seen on the cross section of the intussusception. While on the longitudinal section, we can see that there is something called as a pseudo kidney appearance. And why does this resemble a kidney? That is because of the central mesentery, which looks like a renal sinus fat. And the other sign is that of a crescent in donut sign. This is basically a crescent of the mesenteric fat located along with the bowel loop within the intussusceptions. So now, once we've seen a bowel within bowel appearance on ultrasound, now we need to differentiate between a small bowel and a ileocholic intussusception. Now, how do we do that? In a small bowel type, the epidiameter of the lesion would be less. The mean is approximately 1 to 3 centimeters, and it will be shorter in length. And the fat core is small, linear, and eccentrically located. Why is that? Because there is paucity of fat in the proximal small bowel loops, the mesentery of the proximal small bowel loops. While in the ileocholic type, the AP dimension is larger, and it will be generally greater than 3 centimeters in size. And because of the high amount of fat in the ileal mesentery, it appears as a large central echogenic inner fat core. And also because small bowel is involved, in the small bowel has a smaller outer wall thickness, while in the ileocholic type there is a larger thickness of the outer wall. And the core to wall index is taken. It is the ratio between the central fat core and the outer wall. Because the fat core is larger and the larger in the ileocholic type of intussusception, the core to wall index is greater than 1 in the ileocholic type, and it is less than 1 on the small bowel type. So now we have two cases, both of them showing bowel within bowel appearance. So how do we decide which one is small bowel and which one is the ileocholic type? So in the first one, we can see that the central echogenic fat that is there is linear and eccentrically placed, while in the second one it is larger and it is centrally placed. So the first case would be a small bowel type, and the second one would be a ileocholic type. There are a few other features that favor small bowel intussusception. That is the periumbilical or left upper quadrant location, as well as presence of a normal IC junction, would favor a small bowel intussusception, while the upper quadrant, the right upper and right lower quadrant locations, as well as presence of intralesional lymph nodes, favor an ileocholic intussusception. So now that we've differentiated whether it's a small bowel type or an ileocholic type, we also need to look for a few other findings. For example, there are lymph nodes, presence of a lead point, if there is presence or absence of any vascularity within the bowel loops, any trapped fluid within the intussusception, any pneumatosis, if there is any proximal bowel dilatation, pneumoperitoneum, portal venous gas, or ascites. This is a case showing bowel within bowel appearance, and there is normal color flow is noted within the bowel loops, which actually suggests that the bowel is viable and the patient can be taken for pneumatic or hydrostatic reduction. But in this case, we can see that there is proximal bowel dilatation and a thin streak of fluid which represents ascites. So this finding actually suggests that the enema reduction might not be successful. In this case, we can see that there is, along with the mesentery, there is some amount of trapped fluid. In the final case, we can see that there is, along with the trapped fluid, there is also a longitudinal tubular structure which happens to be a Meckel's diverticulum. And both of these cases, because of the presence of trapped fluid as well as in this case a lead point, there is lesser chances of non-surgical reduction. Here I'd like to mention a few points about colocollic intussusception. It is actually rare in a pediatric age group, and even if it occurs in older children. And the exact incidence is not known. And the lead point is commonly present, which again reduces the chances of a non-surgical reduction. And it is more common on the transverse and the descending colon. They do occur on the right side, but then it will be very difficult to diagnose on ultrasounds because we'll need to show a normal IC junction. Okay, this was a 2 and a half year old child who came with presented with an abdominal pain. On X-ray, we can see that there is bowel gas shadow up to the transverse colon, up to the hepatic splenic flexure. Sorry. But beyond that, there is no gas shadows. On ultrasound, we are able to see a bowel within bowel appearance at the splenic flexure region. So this turned out to be and there was also normal IC junction. So this turned out to be a colocollic intussusception. Radiographs can be done, but they have low sensitivity and specificity. And if they are done, an AP view and erector or lateral decubitus view can be taken. They are done basically to look for signs of obstruction and bowel perforation. Then radiographs, what are the findings that we see in radiographs? They are proximal bowel dilatation till the level of the intussusception, and then there will be paucity of the bowel gas distally. We can see an elongated or rounded mass, a target sign with a central radio hypodense central fat with a rounded area of mass effect, which is actually very difficult to see. And we can also see something called as meniscus sign. So in this first case, we can see that the small bowel loops are dilated. However, there is no presence of any gas shadows in the large bowel. In the second case, again we can see that the proximal bowel loops are dilated, and there are paucity of gas shadow in the large bowel, but we can also see a ill-defined mass-like structure in the right upper quadrant. Even after these cases, we'll need an ultrasound to confirm the diagnosis, and that is why there is the low sensitivity and specificity for ultrasounds. Coming to barium enema, there are two signs called coil spring and meniscus signs. In this coil spring appearance, we can see that the contrast has reached till the splenic flexure, and beyond that, we can see spring-like appearance. That is because the contrast has percolated between the intussusceptum and the intussusceptions, and because the hosta, they look like a coil spring. But in this case, the contrast is outlining the apex of the intussusception, which looks like a meniscus, and this is also called as claw sign. Okay, these are two cases where CT was done. This is a 7-year-old child who is showing a gastroduodenal type of intussusception, and also a ileal type of jejunal type of intussusception. And this was a case for 14-year-old girl where an enhancing mass was noted within the colocollic intussusception, and this turned out to be a case of lymphoma. Coming to management, the non-surgical methods include pneumatic reduction and hydrostatic reduction, and then surgery. A few points regarding ileal type. Ileal is generally a transient type of intussusception, and if there are any features of obstruction, surgical reduction would be preferred. Why? Because non-surgical reduction is not easy, as high pressures are not achieved at the head of the intussusception. And as far as colocollic intussusceptions are concerned, they are managed similar to the ileocolic type. So what are the contraindications for reduction by anemia? If the child is present with shock or dehydration or peritonitis, the child is rather taken for surgery rather than for pneumatic or hydrostatic reduction. Coming to pneumatic reduction, the procedure for it is, first we insert a non-balloon catheter or an infant feeding tube into the rectum, and the buttocks are compressed manually or taped together. And then air is insufflated per rectally in the head of the intussusception is visualized as it moves proximally towards the IC junction. A pressure gauge may be used to monitor the pressure. So how do we know the reduction has occurred? There'll be sudden reflux of air into the terminal ileum, and there'll be a mass at the IC junction, which will disappear eventually. So this was a case of a 4-year-old boy who presented in the intussusception with the head of the intussusception at the right upper quadrant. So after insufflating some air per rectally, we could see that the head has reached till the IC junction. Once it is at the IC junction, but we're not able to see any small bubble gas. Once after we are able to reduce it completely, the mass has disappeared on the next image, and there is now presence of gas in the small bubble. Coming to hydrostatic reduction, in this case, an enema bag with a rectal tube is fitted. Rectal tube fitted is filled with a warm saline or barium enema. In cases where saline is used, ultrasound is used for guidance, and if barium enema is used, then fluoroscopy is used for guidance. And the enema bag is hung at least 100 centimeters above the level of the couch, and a rectal tube is inserted into the rectum, and this time balloon is inflated. And normal saline or barium is allowed to flow into the colon, and under guidance we are supposed to look for the reduction of the intussusception beyond the level of the IC junction. This is a case where bubble within bubble appearance is noted with the hydrostatic with fluid in just proximal to it. This fluid is from the hydrostatic reduction. So once there is reduction of the intussusception, we can see the IC valves with reflux of the fluid into the terminal ileum. So what are the advantages of pneumatic reduction? The advantages are that the success rate is approximately 70 to 90%. It is easier and cleaner technique, and it is easy to confirm a successful reduction in these cases. There are low chances of complications, and even if a perforation occurs, the size of the perforation will be smaller compared to the hydrostatic one, and higher intraluminal bowel pressure is achieved. But what are the disadvantages? The disadvantages are that the patient is exposed to ionizing radiation, and we need to have a fluoroscopy equipment, and we are able to visualize only the intraluminal content. That means even if there is a lead point, will not be able to tell. But the advantages of hydrostatic reduction include that the success rate basically are similar for both of them, and in cases where USG is used, there is no ionizing radiation, and it enables visualization of intussusception as well as the lead point. There is lower risk of perforation because lower intraluminal pressures are achieved, and it is obviously cheaper. The disadvantages include that the radiologist has to be experienced with ultrasound, and as just mentioned, the intraluminal pressure achieved is very low, and there is higher risk of abdominal contamination if there is perforation, because the fecal matter gets into the abdominal cavity, and it can be a very messy procedure. Coming to recurrence occurs in 5 to 8% of the cases, and it is more common in the non-surgical cases than in the surgical ones. Risk of having an early recurrence of intussusception is low within the 24 to 48 hours. That means if the child is if the intussusception is reduced and the child is kept in the hospital for overnight admission, there is a chance that the patient might be discharged and still he or she might have a recurrence. So we should be vigilant regarding that. And depending on the clinical condition of the patient, enema reduction can be performed more than once. So when is the surgical reduction done? It is done in cases where the enema reduction is failed, or if it is not available, if there is peritonitis or the patient is in shock. So the take-home messages are a high suspicion of index is needed in cases of acute abdominal and pediatric cases, because the classical ride of features are seen only in 30 to 40%. And early diagnosis leads to early intervention, which basically reduces the morbidity. And enema reduction has a high success rate and should be the mainstay of treatment wherever possible. Okay. Thank you.
Uh, Thank you, Dr. Manoj. That was excellent presentation, and you had good collection of cases, and it was a very structured and systematic presentation. Uh, Dr. Sravanthi, if you have any queries, if you want to ask anything.
As such, no queries. Actually, the recurrences can be as high as 20%, with most of them presenting within 24 to 48 hours. So usually, once the patient undergoes a pneumatic reduction, after 24 hours, we get an ultrasound done just to cross check if there is a recurrence again, early recurrence. And then if there is no ultrasound documentation of intersusception, we discharge the patient. So in the first 24 hours, it is very high.
I think Dr. Shanti, you also have some presentation. Dr. Manoj, can you show the slides?
And just to add to the reduction part, these days we have started doing laparoscopic guided pneumatic and hydrostatic reductions also, not apart from the ultrasound and fluoroscopic guided reductions. And once we do a laparoscopy reduction or a laparotomy reduction, the recurrence is as low as 5%. And once we do a resection and osmosis, it is almost nil, the recurrence. I just have a few cases which show the intraoperative pictures of the intersusception we did.
Yeah, I think Dr. Manoj is preparing the slides. But, yeah, till he comes live. So I think we have few queries. Yeah, one of them is how would you decide like after we give intersusception and ultrasound, how do you decide like whether to do a conservative management or whether to go ahead with the pneumatic or hydrostatic reduction? What will be your criteria?
One, clinically the patient is stable and there is no history of obstruction suggestive and is very much stable. We usually give a trial of pneumatic reduction, even though there is a prolonged duration of history, like 3 days or 5 days also. So, but if the ultrasound is saying the bowel can be gangrenous, there is poor vascularity, there is fluid in it, then we usually prefer going for a laparotomy or a laparoscopy.
So for all interception, you go ahead with reduction or you wait and watch without pneumatic or hydrostatic, just waiting and watching.
Ilioileal jejunal intersusceptions are usually transient, so small bowel interception we wait and watch. But if they're persistent, then we have to suspect a lead point and then go for a laparotomy because reductions won't help in a small gut interceptions.
At what point you go ahead with CT?
If the ultrasound is showing persistent, at least 3 ultrasounds are showing persistent intersusception segment in the small bowel, then we get a CT done.
Yeah, I think Dr. Shanti broke up. Dr. Manoj, you can start that PPT. I think by the time you start, maybe we can get
I
it back.
think I am sharing it right now.
Yes, ma'am. Yeah. I think Manoj, you can go to the next slide.
Yeah. So this patient presented at is 11 months old. They presented at 3 days, symptoms of 3 days. As you can see, the obstruction has started as seen by the air fluid levels and dilated bowel in the X-rays. So on laparotomy, this could not be reduced pneumatically, so we took up for a laparotomy. As you can see, the small bowel is going into the large bowel and it has been reduced. And there is mild edema at the IC junction, but otherwise the bowel is fine without any gangrene or necrosis patches on it. Can you go to the next slide? This patient is also around 1 year of age. He has come to us with a CT which was done outside. As you can see, there is a target sign in his right iliac fossa in the CT scans. And there is persistence of contrast in the X-ray film which we have done, and the child is already in obstruction as seen in the multiple air fluid levels in the X-rays. Next slide. So here you can see the intersusception segment in the first photo, and as we are trying to reduce, even though we use mop compressions to decongest the bowel and then reduce it, there is a small serosal tear if you can appreciate on the bowel. And you can see in the third photo, which I'm being pointed with the forceps, that the bowel wall is partially necrotic and is almost like an impending perforation. So in this particular case, we have to do a resection and osmosis of the bowel segment. Next slide, please. So, as Dr. Manoj has said that there are few medical cases like HSP and Pierce which can present with polyposis and intersusception. This child is a 10-year-old female. You can see the mucocutaneous lesions in the first picture, and the CT shows the intussusception, which is at the DJ flexure. This is actually retrograde intussusception, and we laparoscopically reduced it, but there was a polyp, which is the lead point, so we had to do an extracorporeal dissection and osmosis for this patient. Next slide, please. This is also a similar picture where we did a laparotomy for a jejunal intussusception because this is at least around 10 centimeters from the DJ flexure and there was a polyp in it. So the child underwent dissection osmosis for this. So this is where we intervene in a small bowel intussusception. That's all. Thank you.
Okay. Thank you, Dr. Sravanthi. These are very nice cases. And before concluding the presentation, I just had a couple of queries. Do we ever use barium enema like for either diagnostic or therapeutic purposes in
No,
intussusception?
currently we are not using barium anymore for any diagnostic or therapeutic procedures. Either we do an ultrasound or directly go for a CT because once if there is a rare chance of perforation, barium will cause more contamination and more sepsis and
And between hydrostatic and pneumatic adduction, like, what would be the preferred modality? Is it
I
just person
think
to
that is being personal choice for a doctor or institution, but like he mentioned in his slide already, hydrostatic reduction has more chance of larger bowel tears if there is a rare chance of perforation and more contamination which will lead to sepsis, whereas pneumatic has a limited, easier to manage because of less contamination.
Okay, I think we are well past our time. Dr. Manoj, if you have any queries, I don't see anything in chat. Dr. Manoj, if you have anything to ask Dr. Shan.
Okay.
Okay. Thank you, Dr. Manoj, and thank you, Dr. Shanti. With your permission, I think I would like to close the session now.
Yeah,
Thank
thank you.
thank
Thanks for the invitation.
Thank you, Manoj. Thank you, Dr. Khalid.